Introduction to Nursing Concepts, Nursing Process Part 5, Martha Olson. Our last segment now is documentation. The purpose of the healthcare documentation is to make sure that we have a legal document, it's correctly written, it helps us communicate with other people in the healthcare community that need or have access to that medical record, and also it's our legal defense if we would be called into a court of law. Our nursing reports then, a lot of them are taped, or if you work in a hospital, they will give bedside report now. And so we document and record information or exchange information with other caregivers in many different ways. Our confidentiality is crucial. It's the patient's right. It's an employee expectation, and it is also, as of 2001, a HIPAA law. The purpose of the medical record is to communicate between shifts. Doctors read nursing orders, nurses read doctor's orders to keep our communication lines open. As I said, it's also our legal defense. We never want to chart anything that didn't happen or we anticipated. We want to make sure that we are charting verbal orders and have a doctor sign them. If a doctor tells you take the Foley catheter out when you're making rounds with him, but he does not write that as an order, you need to go in then and write it as a verbal order, but within 24 hours that physician has to sign that. We don't want to chart in advance because things happen. And it used to be that nurses would chart about 6:30 in the morning that the patient was fine, and they checked on them at 7:30 so that when 7:30 came and report was over, they could leave. But what happens when the patient expires or falls out of bed at 7 o'clock and you've already charted at 7:30 that they were fine and you gave a report to the next shift? And then we want to make sure we get the correct date, because that is how things are communicated, and with the incorrect date it could cause a medical error. We also use the medical record to financially bill Medicare or Medicaid and insurance, and without that correct documentation in the medical record, they can refuse payment. An example I can think of is breathing treatments or the handheld nebulizers. If a nurse gives one and forgets to chart it, they can refuse to pay for all 15 of the breathing treatments that were given during that hospital stay. So many people back in medical records are going through and looking at charts to make sure everything is charted before they send it off for payment, so that we don't lose money because we did not chart. It's also a form of education. When you get to the clinical site and you sit down and read a chart and read a patient's medical history, you are learning from that. Our assessment is in there. Research uses medical records to see how many patients, and complete their research, and then we also use it for auditing purposes. The chart has to be factual only. We want to keep our opinions out of there. So if you would have a patient come into the ER and he smells of alcohol and he's staggering and he's kind of loud and belligerent, we would not want to put in that chart that the patient is out of control or anything like that. We want to just chart facts. We want to keep it very accurate. It needs to be complete. We don't want to leave any areas that are incomplete or it looks like they wonder, did it happen or did they just forget to chart something? We want to make sure we keep the most current vitals in there, because doctors access the medical record looking to see change in vital signs. If a patient's running a fever, they might call over and order an antipyretic. So we want to keep it as current as we can. The other reason you really want to keep that current, if I'm working in a small hospital and I get a unit patient and I have been taking care of patients on the medical floor and I very quickly have to go over to the unit to admit a patient on a ventilator, the nurse that picks up my patients then would be able to see that my 9 o'clock meds were given, that my 9 o'clock vitals were obtained and charted. Keeping things logical, and also in charting we want to avoid using the words such as I or me. We want to use the nurse instead of the I or me statements. Parts of the medical record, the first part, and this has changed a lot because of most of our charting anymore is online. It is an electronic medical record, also known as EMR. But But in a hard copy, you would see then that face sheet that has their name, their insurance, their address, their phone number, their next of kin. Then comes your medical treatment plan that has the history and physical that the doctor completed, your physician's orders, the progress notes. Progress notes are what the doctor is thinking at the time, and he may write that he saw the patient today, they're progressing well, the white count is back to normal, one more day of IV antibiotics, and we'll probably send home tomorrow after dinner. It helps you to kind of know what the doctor is thinking or planning for that patient. Any consults, that would be for specialists. So if the urologist is consulted, they would come in then and have their own place to document in that. There's our nursing care plan that we learned earlier how to compose and put in there. Then comes the part where the nurse has their information. Our admission assessment is documented. A graphic sheet shows our vitals in a linear way so that we can see that every night at 9 o'clock that temperature spikes, but yet it goes down throughout the day. Our daily flow sheets are things that help us to see on a daily basis the bath was done and other things were done. And then our flow sheets such as IV flow sheets, so it's just a specific form that a patient that has an IV would have an IV flow sheet, so we can remember to chart that a 22 gauge was started in the right hand, first attempt, it flushes easily, no redness noted. And then the last part of that is your medical record for medication administration, also called the MAR, and that's where you go electronically to look to see what meds you have at 9 o'clock, what meds you have at 10 o'clock in the morning. To see documentation of a wound that was changed yesterday, we would then go into that nursing daily flow sheet. How the patient tolerated ambulation would also be documented in that flow sheet. Other things that we want to see in that chart are your Cardex, possibly a surgical record, if they have a living will or advance directive, our plan for discharge, and then any lab or diagnostic. The Cardex is something we've really gone away from, and that is simply because it used to be what we would chart on every day to give report, but now we just pull the computers around with us and go to the front page that tells the information that we need to give report. Types of documentation then, we have progress notes. It's more traditional and very time consuming, but it gives a very good description of what happened. So anything out of the ordinary, if I have a hard time charting in the areas where you just simply click the boxes, I would go to a nurse's notes or a type of progress note to be able to talk about the patient was ambulating in the hall, became very short of breath. We checked the oxygen saturation and it was only 88%. Oxygen was applied. He was put back in a wheelchair and taken to his room where he maintained his SATs and rested comfortably after that. Some of the other types of charting, your problem-oriented is what physicians use. You'll hear it called SOAP or SOAPy charting. Your subjective is what the patient says. So patient complains of pain to his left toe. The objective, the physician would chart or the nurse would chart that the right great toe is reddened and very tender to touch. The assessment then is again looking at that assessment of the patient, that maybe their uric acid levels are up, they haven't had a pain pill. The plan is that this patient possibly has gout. Let's run some tests. Our intervention is to give pain pills and some allopurinol, which is a medication for gout. And then evaluation is to follow up tomorrow and see if the pain has been relieved and that toe is less red and swollen. So it reflects our critical thinking and how we are using that nursing process when we use this form of medical record. The other one is more focused, and it is a result of a direct concern. So if I walk in the room and a patient is having severe chest pain, I am going to use a narrative to organize what I collected for data, what action I took, and then what result came of that. It might be that he has chest pain, he's diaphoretic. My action is I give a nitroglycerin sublingual, and the result is the patient's chest pain resolves. He is taken to the cardiac cath lab where they do a cardiac cath on him, and he returns then to the intensive care unit. Charting by exception is a type of charting that you will see used quite a bit. It is what you only chart the abnormal. So you don't go in and say the patient has active bowel sounds. The only time you would chart about the bowel sounds is if they are hypoactive or not present. It is a kind of charting that scares me because I think I did and checked all of these things. How can I prove that I did listen to the bowel sounds? Because if they're normal, I wouldn't chart anything. But how do I prove that I even check the bowel sounds? So we want to make sure we are always charting defensively. We want to make sure that we chart things in there in a very clear communication that's written in a very clear way for us to be able to show in our charting that we have done the correct things. We follow the scope of practice and our policies and procedures of that facility. Our guidelines are to stick only to the facts. Don't start pulling in other ideas or thoughts that don't pertain to that or that could be looked at in a court of law as why was that written in there. We don't want to label patients as argumentative, uncooperative. If they are being uncooperative, we would chart patient refuses meal, patient refuses to get up and ambulate, states, I want to get out of the hospital, this is a terrible place, unquote. We want to use very neutral language if possible, eliminate any bias, and then keep that medical record intact at all times as far as keeping it accurate, up to date with the facts. Things we don't want to chart are staffing problems. The nurse was pulled to the intensive care unit for a new admit, and I had 10 patients to take care of, so the bath didn't get done today. We would not want to record any conflicts of staff. The nurse before on the shift from the day shift reported that the patient was uncooperative with his bath. We wouldn't want to chart anything like that. We'd never report an incident report in the medical record. We fill out an incident report, but that goes to the quality assurance nurses that look at that to help us identify why the incident happened. We would only chart the facts around that. So if you have a patient that gets around the side rails and falls out of bed in the bathroom, you would chart that the patient was found in the bathroom on the floor. He reported he was trying to get to the bathroom and fell. And then you would chart that the doctor was called, he had no bruises, he was escorted back to bed, and what his vitals were. You would go in then in another part and make an incident report that the patient fell, what time, the doctor was notified, but you never want to put in your medical record that an incident report was filled out, because then that becomes a part of that medical record and can be called into a court of law if they want to. Don't chart casual conversations or words like mistake that are associated with errors. Our computerized charting is pretty much taken over. Most of what we chart in the hospitals is computerized. If you get to some of the long-term care facilities, they may still be doing charting on paper and pencil or paper and pen. The minimum data set is called MDS, and that is what we use in the nursing home, and that's what flags their payment. And so when you get to care of the aging adult, I have the MDS coordinator come and visit with you about her job and how she does the charting. And again, the variance or incident reports are not part of that permanent medical record. They are simply completed so we can figure out why patients are falling, or why we have so many IV infiltrations, or other things to help us improve the quality of cares that we give. So we only want to document things in an incident report that are out of the ordinary, that happen, that potentially could be a problem later on. What we want to write in an incident report is to inform them of what happened, so that again our risk management can evaluate what happened and we can maybe make corrective action so that it doesn't happen, or we can minimize that from happening again. An incident report is not part of the medical record. It is only kept by the quality assurance nurse. Our time is up. We will be practicing documentation and talking more about that in class. Thank you very much.